everybody. This is Ryan Finkel, one of the new fellows over here, for those that I haven't met, and today's topic is going to be degenerative spondylolisthesis. So in general, spondylolisthesis is described and classified into 6 different subtypes: dysplastic, isthmic, degenerative, traumatic, pathologic, and post-surgical. Today we're going to be mostly focusing on the degenerative subtype, which includes degeneration of the facet joint capsule. So here's a little bit of an overview about what we're talking about for some background in epidemiology. So spondylolisthesis of L5 and S1 was actually first described by a Belgian obstetrician. Oddly enough, Dr. Herbeneau in 1782, when he first noted obstruction of the pelvic outlet during delivery, caused by what he termed as lumbosacral dislocation. He subsequently coined the term spondylolisthesis from the Greek word spondyle, which is vertebra, and olisthesis, which means to slip, in the 1800s. And subsequently after, it was noted that a pars defect was actually found and required for this kind of slip to occur. It wasn't until 1950 that Dr. McNabb described the spondylolisthesis with an intact pars, which now is the degenerative subtype. So some definitions, specifically the definition is anterior or posterior translation of one vertebra over the subadjacent vertebra. It's associated with degenerative changes without a disruption or defect in the vertebral ring, or pars. Historically, has been defined as a slippage greater than 3 millimeters or a greater than 5% slip, as seen best on the lateral radiograph. And then kind of just a brief framework and overview of the pathogenesis of the disease. So first, there's this degeneration with overall ligamentous laxity, possibly sagittally oriented facets, which we'll talk a little bit more about later, which then can subsequently lead to narrowing of the disc space with settling of the vertebral segment. Subsequently, you can see an increase in segmental motion and slipping of one vertebra on the subadjacent vertebra. And this increased segmental motion can lead to arthritic change, facet hypertrophy, and ligament buckling. Interestingly enough, you can then subsequently see secondary stabilization of that unstable segment with overgrown facet joints or facet cupping, which we'll again talk about a little bit later. Again, some epidemiology, it's typically in patients greater than 50 years old. Females are more predisposed to this at about a 1-to-5 ratio or 5-to-1 ratio. Black women are about 3 times more frequently affected than white women. It's most commonly at the L4-5 level. The slip rarely exceeds 30% slip, but it can happen. And again, it's usually asymptomatic, but can progress to spinal stenosis. Here's a study from 2007, just kind of overviewing the epidemiology. It was about 4,000 patients, 1,500 were men, 2,600 were women. And it showed that the prevalence of degenerative spondylolisthesis was about 6.3%. 8% of those were women and 2% were men. The average age for men was 68 and the average age for women was 71. Notably, significant risk factors to develop this disease for men just included age, but for women, it was age, BMI, height, weight, and increased lumbar lordosis. Notably, there was no association with any smoking or heavy lifting in the history or seated occupation. All right, next we're going to talk a little bit about the pathoanatomy. So some risk factors that have been associated with developing degenerative spondylolisthesis include transitional anatomy. It's postulated that increased lumbosacral rigidity has been shown to increase the mechanical load on the more cranial segment, which is usually at L4-5 in the transitional segment. I thought it was pretty interesting, pregnancy and oophorectomy, which ultimately has a physiologic state of decreased estrogen, which can speed up this process and increase the degeneration and laxity in general in patients. Conditions with generalized laxity, such as Ehlers-Danlos or other collagen processing disorders, have a predisposition for this disease. And again, diabetes, again, has a predisposition for the disease as well, too, just weakened collagen cross-linking due to increased N-glycation products. Sagittally oriented facets in the axial plane show abnormal loading patterns, which can expedite the degenerative process as well, too. You can appreciate that, you can picture that diagram on the right there. If the facets are more sagittally oriented, there's not a lot kind of stabilizing any sort of anterior-posterior translation. And again, increased pedicle facet angle ultimately allows for increased stabilization of the inferior joints as well, too. Here's a meta-analysis from 2017, which ultimately included 17 different studies, which highlighted this concept of sagittally oriented facet joints. It further showed that patients with degenerative spondylolisthesis had about 10 degrees more sagittally oriented facet joints on average compared to age-matched controls. And here's another interesting kind of historical study from 2007 that attempted to analyze specific spinal pelvic parameters in patients with degenerative spondylolisthesis. It looked at about 40 patients with degenerative spondylolisthesis and 150 controls. And what they found was that pelvic incidence was actually significantly greater for patients with degenerative spondylolisthesis at a 12-degree clip, so 62 versus 50 degrees. And after they matched according to the pelvic incidence, they found that the degenerative spondylolisthesis group had anterior translation of the C7 plumb line on the sagittal, loss of segmental lumbar lordosis, and in some cases there was even some segmental kyphosis depending on the severity of the slip, and there was a decrease of the sacral slope. All right, next we're going to move on to some clinical features, sort of what we're seeing in the clinic when these patients come and present. So as clinicians, kind of what we'll see when patients come in to the office is usually neurogenic claudication or pain is the primary symptom that they're describing. Most patients with this issue describe pain at a 94% rate. There also can be some numbness in various dermatomal distributions depending on the level that is listhesed. Weakness can be present, not as common, but it can be present and kind of tips us off to some more severity of the disease potentially. Oftentimes, back and buttock pain, kind of playing into that neurogenic claudication or radiculopathy, pain, paresthesias, or weakness associated with walking or standing. Lower extremity neurologic symptoms can be present in spinal stenosis, and about 3% have bowel or bladder symptoms. And again, those are more of the severe cases. On physical exam, patients, the classic shopping cart sign, walking uphill is easier, and that's, again, to increase the canal volume as patients flex forward. Hyporeflexia can be present as the peripheral, as the nerves are kind of being compressed and that neural arc is dampened. And then again, loss of sensory or weakness in the various dermatomal or myotomal distribution. And something I thought was important, maybe overlooked sometimes, is just making sure we check pulses on all these patients because vascular and neurogenic claudication can a lot of times present pretty similarly. And, it can be easily forgotten, but very important to make sure that we're checking pulses on patients. So some radiographic analysis, standard imaging studies, AP and lateral views with flexion extension views are paramount. A lot of times patients will come into the office with MRIs, and those are obviously important for us to evaluate the neural elements and kind of get a better look at what's going on in these patients. And then the Myerding classification, something that is pretty historic and a good review, is just grade 1 to 5. Grade 1 is essentially a 0 to 25% slip or up to 1/4 of the cranial vertebrae on the caudal vertebrae. And again, it goes all the way up to grade 5, which is a spondyloptosis, which is a complete dislocation or falling off of the cranial vertebra on the caudal vertebra. You can also measure patients' pelvic parameters, which can be helpful. Patients' pelvic incidence, sacral slope, lumbosacral angle can give us a better understanding of their global alignment, as well as a propensity for instability and disease progression. This was kind of a newer study in the literature looking at is there any additional value to flexion extension radiographs in the degenerative spondylolisthesis population. So it was a review from 2021 looking at patients with grade 1 listhesis. They used a cutoff of 7 millimeters of listhesis as a surgical indication for fusion. And ultimately, they compared patients who had a supine MRI and upright x-rays versus those with flexion extension views. And out of the 191 patients in the surgical cohort, 31 patients had additional motion, which they defined as 3 millimeters or greater, seen on dynamic flexion extension views compared to a supine MRI that would potentially change management. So more than half of those patients have less than 7 millimeters of listhesis on their upright x-rays. So you can see how there's pretty significant data that can be elicited from these additional views. And then it has kind of a more historical imaging study, historical paper rather. This was an interesting study highlighting how there can be segmental motion in asymptomatic volunteers up to 3 millimeters. And generally, this is kind of how we get that 4 millimeters of translation, which is classified as pathologic. Here's a lot of times, patients they'll come in with advanced imaging, not always indicated, but sometimes they do. And there's a lot of nuanced findings that we can be on the lookout for to help us guide treatment in these patients. Here's a clip of a study that highlighted some of these findings that can be present in the patients and give us some additional information. So kind of going left from right, you can see some increased fluid in the facets, which is, I think a little bit subjective, but that it could be a finding. The B is a synovial cyst you could see, which oftentimes can key us in on some segmental or focal instability at that level from hypermobility. C is some interspinous fluid, which I hadn't really been on a lookout for, honestly, a lot of times in the MRI, but this can be a specific finding to segmental instability. D is facet joint hypertrophy, which you can see in various pathologies, not just degenerative spondylolisthesis, but it can key us in on overgrowth, trying to stabilize a segment. And E is a vacuum phenomenon, again, not specific to spondylolisthesis, but can key us in on a degenerative disc process. Okay, so now kind of going on to a little bit of the natural history of the disease. This was a study out of Japan, which is one of the longest studies in terms of like follow-up that's in the literature to date. It looked at the natural evolution of the disease with a minimum of 10-year follow-up and ultimately evaluated 145 patients with degenerative spondylolisthesis. 100 of them initially did not have any neurologic deficits, and 35 of those patients had neurologic deficits that were indicated for surgery, but ultimately declined. So this was the kind of their population of interest, and they followed them over 10 years. Interestingly, the listhesis progressed radiographically in a third of the patients, but there was no clinically worsening back pain or claudicatory pain in these patients. 90% of the patients with disc height loss actually had their back pain improve over follow-up. So one could consider that concept of secondary stabilization of a segment as a potential source of this finding. And 25% of the asymptomatic patients with pain or neurologic symptoms eventually progressed to progressive neurologic decline. And those with the initial neurologic deficits that declined surgery generally experienced worsening of those symptoms over 10 years. So I think a take-home point from this study specifically would be that the disease process can take many clinical forms. And again, we have to kind of follow these patients and tailor our treatment towards each individual chief complaint. So briefly, we're going to touch on some non-operative measures. These are not specific to degenerative spondylolisthesis in themselves, but something to have in our back pocket. And those are anti-inflammatory medications, activity modification and conditioning, weight loss, PT, steroid injections, and concomitant diagnosis of osteoporosis and management if indicated. This was a study not, again, specific to degenerative spondylolisthesis, but looking at patients that had axial low back pain and radicular pain. And the efficacy of weight loss. It was a prospective study, which I thought was interesting that they were able to do this. We looked at 30 morbidly obese patients who underwent bariatric surgery for weight reduction. They measured patients pre-op and at 1 year post-op. On average, there was about 35 kilograms of weight loss and a 14-point BMI reduction, so quite significant. And they noted that they actually had a paradoxical increase of disc height at L4-5 from 6 to 8 millimeters over this course of the study, and both the axial and radicular back pain dramatically increased. So when we tell patients to, exercise, lose some weight, it's not just to get them out of clinic, it's to actually help themselves and potentially avoid any interventional measures on our end. And this was a study looking at the efficacy of physical therapy and steroid injections. There's a prospective randomized trial of 29 patients for 6 months, and they broke patients down into groups that got PT injections or age-matched controls, with the caveat that all the patients actually got a home exercise program and anti-inflammatory medications at home as well too. And they noted that there was actually pretty significant improvement in all the groups, which is pretty interesting. I thought the treadmill walk test, sit-to-stand test, and the weight carrying tests were sort of the measures they looked at in terms of like physical function, and they improved in all the groups. There was significant improvement in the control group too, but less so than either group. So kind of shows us that time or maybe the anti-inflammatory medications by oral intake have some good effect there too. In the sport trial, this is a trial that we all kind of known and kind of in our training. There was a subset analysis that actually got published pretty recently that looked at patients that with degenerative spondylolisthesis that were being initially non-operatively managed. 192 did not receive epidural injections, while 74 did, and ultimately there was no difference in the rate of surgery or outcomes between the groups over a 4-year span. All right, surgical management. This is what we're all here for. So I think it's important, there's a lot of ways to get lost in the weeds a little bit on this stuff, but if you break it down to the goals of surgery or the goals of treating the patient in general, like I think it actually becomes a little bit more simple, at least for me. Um, so one, neurologic decompression. These patients will be coming in, if you're indicating them for surgery with neurologic issues for the most part, and you want to make sure that you're able to maintain and achieve a neurologic decompression and maintain that neurologic decompression. Um, Stability of segmental instability, stabilization of segmental instability. So again, if patients have segmental instability, that's the reason why they might fail a neurologic decompression if that's all you're doing. So again, if the main goal is decompressing the neural elements, and you have to evaluate for segmental instability to make sure that you're not just decompressing them and then they, are unstable and getting worse in like a year. Durability of treatment, that kind of all ties into the first 2 points. And then if there's any sort of deformity correction, you want to keep that in mind, especially as the data and literature on all these parameters are coming out. You want to make sure you're not creating a bigger problem in the future. So what are some surgical indications? Symptoms that are debilitating and recalcitrant to non-surgical measurement, pretty obvious: radicular pain, neurogenic claudication. Patients who presenting with any bowel or bladder dysfunction or progressive weakness should be expedited in their surgical management. So we're going to do a little bit of an overview on some of the historical sentinel studies and then some of the newer concepts. So in a review by Herkowitz and Kurz, there were 50 patients who had spinal stenosis associated with degenerative lumbar spondylolisthesis, and they were prospectively studied to determine if posterolateral fusion provided better results than decompression and laminectomy alone. This study found that patients treated with laminectomy and arthrodesis had significantly less leg and back pain and a significantly higher proportion of good to excellent overall clinical results compared to patients who just underwent laminectomy alone. And something that, sorry, I thought was interesting, that if you look at table 1, that all the patients that received fusion versus decompression alone had pretty similar pre-op listhesis obtained on all radiographs. So it kind of shows us that this is quite a historical paper, and maybe the concepts were not as up to date at the time. But again, it's good to see. It's another study. This was an interesting study. Historically, I looked at the difference in instrumented versus non-instrumented fusions for degenerative spondylolisthesis, and they had 76 patients that were randomized into instrumented or non-instrumented single-level decompression and fusion with a minimum 2-year follow-up. The patients that received instrumented fusion had a much higher, significantly clinically, had a significantly higher fusion rate at 83% compared to 45% respectively. But I thought it was interesting, there was no significant differences in clinical outcomes at 2 years. One would assume that a pseudo would have some sort of clinical differences, but again, the 2-year follow-up might be not enough time to capture these patients, so that's a limitation. So this was a follow-up study that kind of looked at that exact point that I brought up. So this was a study with 47 patients with average follow-up of about 7 years. And they found out that those with a solid fusion actually had significantly better clinical outcomes than the patients that had a pseudoarthrosis. So the authors concluded that a successful fusion had a clinical benefit at long-term follow-up, and that instrumented fusion should be considered in patients that were indicated for a fusion in the first place to minimize this risk. And again, that's sort of all we're seeing, or most of what we're seeing now. So here's a sport trial, what I alluded to before. This was a multi-center randomized control cohort with a concurrent observational study. And it was 13 clinical sites across 11 states starting in March 2000. Had a huge grant from the NIH, $15 million. And each trial was designed with 2 branches. There was a randomized and an observational cohort. They looked at primary outcomes with the SF-36, the bodily pain map, physical function scales, and the ODI. And secondary measures they looked at were patient-reported outcomes and satisfaction. In the degenerative spondylolisthesis arm, there were 304 in the randomized side of things and 303 in the observational cohort. What they found is that there was actually a really high rate of crossover in the randomized cohort. 36% of the patients in the surgical cohort elected non-operative treatment, and 49% of the non-operative treatment elected to undergo surgery by 2 years. So that's like half of the patients. What that means is that the intent to treat analysis, the randomized cohort found no significant difference among the primary outcomes. But if you looked at the as treated analysis, they found a statistically significant difference across all primary outcome measures that strongly favored surgical treatment at all time points, which were 2, 4, and 8 years. They also found out that reoperation was about 22% at 8 years. Half of those reoperations occurred in the first 2 years. About 45% of those were due to late complications, and 36 of those reoperations were due to local wound complications. And factors that were associated with reoperation were increased age, advanced stenosis, mostly back pain, lack of neurogenic claudication, not having PT, and higher leg pain scores. Here are some studies that got published in pretty high impact journals. This is the SLIP study. This was a randomized controlled trial published in the New England Journal of Medicine in 2016. One of my mentors always used to say, whenever an orthopedic study gets published in the New England Journal of Medicine, you should probably read it. So this looked at spinal laminectomy versus instrumented pedicle screws, hence the SLIP acronym. And it looked at 66 patients with stable grade 1 SLIPs randomized into laminectomy or laminectomy with fusion. They followed the SF36 as well as the ODI at 2 years. Follow-up was 90% at 1 year and 86% at 2 years, but kind of fell off at 4 years of 68%. They found that there was no difference in complication rate, but fusion did have more blood loss, longer hospital stays, and longer OR times, which I think you can extrapolate. The fusion group had a greater increase in the SF36 score at 2, 3, and 4 years. The ODI was not significantly different, although trended positively towards the fusion group. And cumulative reoperation rate was 14% in the fusion group and 34% in the decompression group. Here's another high impact literature in the last 10 years. This was a randomized controlled trial from 2016 in the New England Journal of Medicine. It looked at 247 lumbar stenosis patients, with 135 of those having degenerative spondylolisthesis. And there were two main groups: decompression alone versus decompression and fusion. The primary objectives here were the ODI-VAS score, 6-minute walk test, economic evaluation at 2 and 5 years post-op, which was kind of a unique endpoint. They found out the ODI-VAS scores, the 6-minute walking test, and walking assessments in general were notably not different at all at 2 or 5 years. There was greater OR time, blood loss, and length of stay for the fusion group. So similar conclusions to the last study, the SLIP study, and no difference in reoperation rates. All right, so there's obviously a lot of heterogeneity in the literature, and there's a lot of heterogeneity in surgical techniques, especially when dealing with this kind of pathology. So this was a study that looked at as a non-inferiority study that was published in JAMA from a Norwegian database looking at microdecompression versus decompression alone. So microdecompression was actually defined as a hemilaminoforaminotomy with preservation of the midline structures and greater than 50% of the facet complex. So sort of what we think as a minimally invasive decompression going through our training now. And after matching, 570 patients included for comparison with the goal of ODI improvement of at least 30%. They ended up finding that 68% of patients improved in the micro decompression group and 72% in the instrumentation group had improvement. So what does that mean clinically? It means that they ultimately found that micro decompression alone was associated with a shorter operating time at 90 minutes to 180 minutes, shorter hospital stays, and clinical effectiveness of micro decompression alone was non-inferior to decompression with instrumented fusion in stable listhesis. All right, so kind of briefly talking about interbody fusion. So if fusion is indicated, the patient has an unstable slip, or you have a long discussion with the patient in clinic, and that is the best treatment officer for that patient. Interbodies can provide some key benefits overall. The first of which is anterior column support. The second of which is there is some literature demonstrating improved fusion rates with interbodies. And another point is that if restoring sagittal parameters like lordosis or segmental alignment is required, certain interbodies can be a powerful tool, such as A-lifts, laterals, T-lifts. And also, they are useful in increasing neuroforaminal height, so they can help with secondary or indirect decompression as long as we're not overdoing it and not preferentially distracting the anterior part of the vertebral body, which would paradoxically potentially close out the foramen. Okay, so some studies looking at different types of fusion. So this was a meta-analysis between posterior lumbar fusion and PLIF for isthmic and degenerative spondylolisthesis. It looked at 8 prospective studies with 723 patients. And it showed the interbody group had better clinical outcome and a higher fusion rate compared to the non-interbody group. And there was no significant difference or postoperative complications or blood loss. Kind of points us in the direction of using interbodies when indicated. This was a study out of China looking at lateral lumbar interbody fusion from 2021. So it was 95 patients with single level grade 1 or grade 2 degenerative spondylolisthesis at either L34 or L45. There was 54 standalones, 41 laterals plus posterior instrumentation, and patients selected their treatment actually after discussing with the surgeon. They found that standalone laterals had a shorter OR time, shorter bed rest time, less intraoperative blood loss. They measured post-op CRP and CK, which they thought was a surrogate for tissue damage in general. They had greater improvement in post-op VAS scores and ODI. Ultimately, 6 patients, or 11%, underwent posterior fixation for subsidence or subsidence, which I think is probably, which we would think is probably a little bit too high. But that kind of brings us to our next study, which is looking at lateral lumbar interbody fusion with posterior instrumentation. So this study was one that looked at, again, what I kind of just mentioned, and it looked at laterals plus perc screws, and they noted that there was improved anterior and posterior disc height, improved segmental lordosis, and significantly less subsidence, 10% versus 33%, with a significantly lower revision rate, sort of showing us that in the right patient population, we should be considering backing these laterals up posteriorly. So another study this is pretty recent, this from 2025 of the Global Spine Journal. This was a retrospective chart review of 1,156 patients. 267 of them had ALIF, 889 of them had TLIF or PLIF. Patients who underwent ALIF or PLIF or TLIF due to spondylolisthesis at the 4, 5, or 5-1 segments were reviewed from a large center over the course of 10 years. They found that there was increased odds of radiographic fusion in ALIF, shorter length of stay, and less blood loss. Interestingly enough, there was no difference in 1-year complications, reoperation, or Cobb angle changes, which I thought was interesting because the teaching usually is that I think ALIF gets a little bit better sagittal lumbar correction, but maybe not in this study. And then again, here's another study looking at is reduction of spondylolisthesis necessary. So this is a prospective cohort study out of Germany from 2019. It looked at 62 patients with low-grade degenerative spondylolisthesis of a single lumbar segment treated with either PLIF or TLIF. They looked at certain measurements, such as the COMI, ODI, or some European study that I hadn't heard of before, the Euro QOL 5D, and they showed that significant reduction in anterior displacement actually did not correlate with clinical outcomes. So it's something to keep in the back of our mind, that perfect reduction oftentimes isn't required for patients to get better. And then there's all this talk about endoscopic surgery lately, and it's sort of a hot topic. So I was looking up to see if there's anything about endoscopic treatment in the form or for degenerative spondylolisthesis. So there really isn't actually too much published out there. It's like a handful of studies, and most of them weren't too good, but this was a reasonable one. This was a multi-centered study, 73 patients from 6 centers across the U.S. with a grade 1 or grade 2 spondy, and they were treated with endoscopic unilateral laminotomy for bilateral decompression in stable slips. Again, they found out that 70 out of 73 patients had an improvement of their pain or neurologic symptoms at 1 year. So I think this highlights that in the appropriately selected patient, there are multiple ways of achieving a decompression of the neural elements, and endoscopic techniques can be useful if performed safely. Okay, so that was obviously a lot, but again, I kind of tried to boil it down into like one slide of take home. So it's obviously a large topic. There's a ton of nuance, especially when you start talking about surgical management. But I do think there are some key foundational principles that will hold true, especially as like the landscape of spine surgery continues to change. The first is that understanding that a complete evaluation is understanding that a complete evaluation is incomplete without dynamic imaging. So it was highlighted earlier that subtle instability can be elucidated on flexion or extension x-rays and ultimately can drive management in a certain direction. So something to keep in the back of our head. You want to keep in mind the goals of surgery of all time. I think as a trainee specifically, it could be really easy to get distracted by technology, new implants, all these companies. But at the end of the day, it boils down to knowing your surgical goals and how to achieve them safely, durably, and reproducibly. The next point is when a patient's been indicated for surgery, management largely consists of either decompression or a decompression infusion. And certainly there's a lot of heterogeneity in that of those two categories, as we saw in the literature review. There can be so much variability from patient to patient in terms of their segmental anatomy, their global alignment, their overall health and function in general. And it's paramount to treat these patients as individuals and to tailor your surgical approach to them, or else I think you can get in a lot of trouble if you treat everybody the same way. I know really isn't an alignment talk, but the more we're learning about and understanding both global and segmental alignment, I think it's really important to understand a patient's spinal shape, especially if we're going to fuse them. I think in my practice, whenever that might be, I'm going to be getting standing full-length spine films on any patient that I perform any fusion on, just to get a good picture of what's going on. By being meticulous and thoughtful about surgical plans, I think we can avoid the disasters that we see of patients being fused in not great positions and coming to us for a bigger surgery. So that's sort of my spondylolisthesis talk. Any questions?
How many questions?
All right.
It's a big topic. Just reflecting on your conclusions. I think you guys really have to be wary of the literature. It's all crappy. And it's crappy because of limitations in the data. Get out there.
You made the point. If you look at the sport trial and the heterogeneity in the type of fusions that were done, the type of decompressions that were done all over the map, right?
Mm-hmm.
All decompressions are not the same.
Yep.
You do laminotomies, preserve the posterior elements and the muscle attachment. There's a different functional outcome.
Yeah. So
you can't laminectomy, traditional laminectomies and laminotomies. Interbody fusions versus posterolateral fusions, open versus MIS. There's so much differential there in early and late outcomes, fusion rates. I think a lot of the sport trial was open posterior fusion.
Yeah, that's what.
Right?
Yeah, it was.
And that's what I used. That's what Ruff and I trained doing. It was a bloody mess. If people before they had infections 5% of the time or more. So all that incrementally disrupts the outcome potential. So we don't have a lot of studies. And you made another point about New England Journal of Medicine. They will selectively pick studies from orthopedists that make surgery look bad. So it's good to look at them, but I would not profess them as great quality studies. Evidence number one is the kyphoplasty study, horrible study. Got great cred in big time journal, medical journal.
Yeah,
it was a horrible study.
Yeah,
and dissuaded people from using that sort of procedure when it actually does help a certain cohort, not the way that they appropriate that. Alignment. I think you're absolutely right. And we're trying to show that over time, but getting alignment right at one level can make a difference. I believe. Whether you need to see the whole spine, that's a little bit of conjecture from the deformity folks, but you need to understand what normal is for that area, that segment, whatever that is, and don't screw that up. It will have a more profound ramification if you screw it up and they have global stuff. But if you get that segment normalized and you can figure out what normal is based on a regional look, that's okay. Most likely. Doesn't burn a bridge.
You speak a little bit to that process that you use to better assess the regional segmental orthosis that you're trying to recreate? Such flaps or such.
Yeah, well, I mean, generally you should be able to see the hips.
Yep.
You should be able to see the third lumbar junction and know what their PI is, their L1 PA, and have some sense of what normal is when their distributional indices are for L4 each segment. Really, you should be able to sort of figure out with that in mind. Any other comments, Greg?
The only other paper I think that gets overlooked. Can you guys hear me okay?
Yep.
Yeah.
The only paper I think that gets overlooked is Pierre Roussel's article on spondylolisthesis. It's a really good one, and kind of discusses spine shape relative to the spondy treatment. But another good one to look at.
Yeah. So that was more instant though. Right.
Hello. Yeah.
Hear that,
So anyways,
Greg?
it's a good one because it kind of goes into a little deeper dive on spine shape and the impact of it on how we treat patients. So, but I think that's the only other one I would point to. You also realize, like you have a little. I think when you just fuse a single segment, you have a little bit more flexibility in your plus and minus of that segment, right? So like if you achieve alignment within whatever, probably 3 or 4 degrees of normal, you're probably going to be okay with the flexibility that exists still above or below. You start fusing more, you start having to narrow how you align patients. But paying attention to it's really important. I think paying attention to your spondy reduction is probably not as important as you showed in the literature. But that's another important point.
That's crappy literature. That's the same argument people.
We've established that.
Well, but Greg, that's
but
the
I think
same. That is the same literature and argument people made to not worry about how you align a single level fusion, right? Because the outcomes are the same for a couple years. We don't know what impact that has on long-term segment disease, return to OR. So
absolutely. And if you think of it as a spline, like we've been talking about, if you have a lot of anterior listhesis, then that spline's jacked up, even if you have a ton of segmental lordosis on it. I think that's what you're saying.
Yeah.
I'm not discounting that. I'm just saying, I wouldn't. I think reducing it is great. I don't think. I don't know the value of perhaps compromising your construct to try to get a better reduction is necessarily the right thing. So
don't rip screws. Yeah. Priority one is alignment.
Mm-hmm.
You can get a reduction without compromising.
And usually, if you're getting your alignment right, you're usually reducing the spine correctly. Like a lot of that goes, they're not independent of one another. A lot of it is happening at the same time. But you guys are also going to see a lot of spondies get decompressed here instead of fused, I think, which is a good perspective. We don't always have to put metal in there. So, all right, great talk, Ryan.